Okay. Welcome back to Advances in Prostate Cancer Screening and Management, presented by Northwestern University Feinberg School of Medicine at OMED Live. You are tuned in to the live session, The Role, Timing, and Utility of Hormonal Therapies in Patients with Prostate Cancer. My name is Dennis Pessis, and I'm Associate Chairman of the Department of Urology at Rush University Medical Center. Before we get started, I'd like to remind you that today's session is a live interactive program that allows me to take questions in real time throughout this presentation. I encourage you to send your questions anytime by typing them in the box located at the lower left-hand side of your screen. Let's get started. The role, timing, and utility of hormonal therapies in patients with prostate cancer is controversial. Today, I'd like to introduce some of the concepts or presentations by our prostate cancer experts throughout the United States to help us evaluate when to start hormonal therapy. Prostate cancer is the most common visceral malignancy in men. 217,000 patients were diagnosed with prostate cancer in 2010. There were 32,000 deaths from prostate cancer in that period. In the PSA era, we've increased the incidence of organ-confined disease, and metastatic disease has decreased. 4% of prostate cancer patients develop metastatic disease, whereas 5-year survival rates for metastatic disease is 30%. 5 and 10-year survival rates are now all comers, 99% and 91% respectively. The lifetime risk of developing prostate cancer is 16%. The lifetime risk of dying from prostate cancer is 2.5%. And as we all know, African Americans have the highest incidence. If you look at the graph on the right-hand side, you can see that node-positive disease has decreased dramatically after surgery. Once we look at the PSA brought into our diagnostic modalities back in the late 80s. At the University of Chicago, Dr. Huggins actually won the Nobel Prize for the use of orchiectomy in patients with prostate cancer. As we know, prostate cancer is overgrowth of adult epithelial cells. All types of adult prostate cells undergo apoptosis when deprived of androgens. The improvement should occur when advanced prostate cancer is subject to castration. As we can see, Dr. Huggins had approximately 21 patients at that time. 3 of those patients did not respond. That should be the first indication of castrate-resistant prostate cancer. And the first report to describe benefits of androgen deprivation therapy came from this study. So in androgen deprivation therapy, which is what we're going to discuss today, we ought to take a look at some of the medications that we are using. The LH-RH agonists, as you can see, they decrease LH via down regulation of GnRH receptors. And what happens with these, however, is that there's a testosterone surge. Some of our experts feel that the testosterone surge may put the patient at risk during that period of time, which occurs right after the first injection of the LH-RH agonist. Of advantage to the GnRH antagonist is that you do not get the surge in testosterone, and therefore takes away that variable. However, anaphylaxis has been described with this medication, but in my experience, it's on a very low incident basis, and therefore should not be a reason to not use this medication. There is an adrenal ablating drug such as ketoconazole. This requires steroids to prevent Addison's disease, as it will shut down most of the function of the adrenal gland, obviously shutting down androgens. The anti-androgens are used along in most cases. If we feel that the surge is going to be important, then we will give an anti-androgen first, at least for 2 weeks to a month. And also we are using anti-androgens in those patients which are failing the LHRH agonist or the GnRH antagonist. The AUA guidelines for this topic may change periodically and will surely be modified by cancer-resistant prostate cancer. Throughout this talk, I will refer to our experts in prostate cancer so that this will help us make decisions in this very controversial area of starting anti-androgens or doing ADT therapy. PSA levels post-radical prostatectomy should remain undetectable. Detectable levels indicate disease recurrence in some patients, but may also be due to the presence of benign glands remaining after the radical prostatectomy. However, this should be a very, very low rise. The rise in PSA should be very slow and keep low, and this should be up to the judgment of the surgeon, knowing what the pathology looked like at the time of the procedure. Biochemical recurrence by AUA guidelines with an initial value of greater than or equal to 0.2, followed by a subsequent confirmatory PSA value of 0.2 equal or greater than will indicate recurrence of disease or persistence of disease. PSA is associated with the risk of treatment failure, and for each 2-point increase in PSA, the risk of progression is twofold. This is a very important part of our evaluation of patients who we might treat post-therapy, including radiation, radical prostatectomy, or any of the other therapies available for localized disease. Recurrence of cancer is evident within 10 years of surgery as approximately 10% of patients with a preoperative level of PSA of 2.6. However, if the level is 2.6 to 10, then we increase that to 20%. And those above that level of 10.0 PSA, we can expect a 50% recurrence of cancer in those patients. However, we must be mindful that high-grade disease may demonstrate a lower PSA level, as these prostate cancer glands do not give off as much PSA in certain circumstances. A cut point of 0.4 followed by another increase may predict the risk of metastatic disease in the post-surgical patient. So again, a cut point of 0.4 with continued increase may indicate metastatic disease or certainly recurrence in the prostatic bed. In post-radiation patients, the PSA level should fall to a nadir and remain stable at 18 months and remain stable following the radiation therapy. Levels of less than 0.2 are uncommon following radiation therapy because we do not ablate all of the prostatic tissue when given radiation therapy. A consistent rise, especially after 18 months, often indicates recurrence of cancer following radiation therapy. The change in PSA in those patients with brachytherapy is quite complex and is associated often with intermittent rises called benign bounces, and we've all experienced this. Any rise of PSA of 2 or more over the nadir indicates treatment failure in external beam radiation and brachytherapy. A PSA of less than 0.7 at 5 years is uncommon in brachytherapy, and the PSA levels may continue to decline even after 5 years, and I have found this to occur in my practice with patients treated for localized disease.